By the end of this By the end of this session, there's just three little objectives that I really want to look at. Is basically I want to help you have an understanding of the role of paramedics and what we contribute during a palliative emergency. We don't see and experience palliative emergencies on a daily basis. They are very few and far between, but when we do experience them, the impact that we have is so important. I'm hoping you'll have an understanding of the treatment modalities and referral pathways that we have access to as paramedics in British Columbia, that we've had for the past couple of years, probably 4 or 5 years now, and how impactful that is to paramedics and patients and families and loved ones in the community. And then also have a bit of an understanding of our communication techniques during a palliative emergency. There is no formal quiz at the end of this. You're not going to be examined on this, but what I do want to encourage at the end of this is leave this community practice with a seed in the back of your mind of curiousness and asking more questions. What do we do? How can we and not disrupt the health service as such, but how can we continually evolve the health service so paramedics like myself and my colleagues that are joining us can continue to deliver and communicate to patients as best as possible, because it's a really challenging environment we're in at the moment. There is a poll that I believe we're going to start with. I'm not sure if Laura has got this keyed up. I may have caused some issues as I'm presenting this. I'm not sure if I need to do this. Oh, there we go. So it should be on your screen. So just very quickly rate your knowledge of today's topic. Very knowledgeable, somewhat knowledgeable, not knowledgeable at all. You can see that the numbers changing. We have a various mix of some people are not very knowledgeable, which is fantastic. Some are very knowledgeable, and then some in the middle, which is great. So I'm hoping by the end of this, that will change a little bit. And if it doesn't, that's also fantastic, because it means we can develop and work on what I need to deliver in the future. I'll probably give that another couple of seconds, and then we can move on if that's okay.
Yeah, the poll has ended. We can just continue.
Perfect. So what I wanted to do to begin with is really explain who or really maybe what a paramedic is. Our role is sometimes rather misunderstood in the community. We are often seen on television programs as interventionalists on ER and Grey's Anatomy. We come flying in, we rescue everybody, and we go rushing off to the emergency department, lights and sirens, bells and whistles blaring. That doesn't really happen anymore. We are very much now moving towards a unscheduled care approach with our care. We know that patients will continue to call 911. We are very much a really good point of access into the wider health authorities and health services. But over the last 4 or 5 years, we're starting to shift our modality a little bit from transporting every patient who calls 911, where we used to transport them into the hospital, into the emergency department, into a more community-based, holistic-based models of care, where through evidence and research, we know that patients want to stay at home. They want to receive good quality care at home. And then be able to access services far beyond what we can provide as a 911 service. And that's what we're really aiming to do in BC Emergency Health Services with various pathways. And the palliative pathway is one that's very close to my heart through experiences and knowledge and education over the past 10 or 11 years working in this role. We are really uniquely positioned to have these meaningful conversations during a moment of crisis. I'm very acutely aware that as a paramedic, when I respond, even though as a operational leader, I'm still a frontline paramedic, I will respond to a patient's home address in what is possibly their worst time of their life. Not many people will phone 911 just for a conversation with us. They phone us for purpose. And I'm invited into their home, and it's a very privileged position to be in. And I have a role and a responsibility to make sure everybody understands what we do as a whole. So introducing these essential conversations as a framework really connects patients in a way that we respect their wishes and their cares and their goals of care. We really look at three big fundamental aspects of having that conversation, and it's really defining what an essential conversation is. It's relating them to the paramedic scenario and what we're bringing to the event at that time, and what we can do to deliver best care. Then it's providing actionable steps for implementing the practice, and that is really important. If I say that I'm going to do something, the patient is going to hold me accountable for that. Their relatives are going to hold me accountable for that. And I fully expect that as well. Same with my colleagues. If I say I'm going to do something within my communication style, I've opened that accountability line there. And it's a really important thing that we do that with intent. But the communication and these conversations don't really start when I walk through the threshold of your door. They really start with my amazing colleagues in the dispatch centres, in the three centres around BC, in Victoria, Vancouver, and in Kamloops in the interior, with the colleagues when you phone 911 and they're triaging and asking you so many questions in a very short period of time. The conversation and the essential conversation really starts there, and they're a fundamental part of what we do every day. And I don't want that to be forgotten because sometimes the questions that they ask provide us some really, really good information as a responding paramedic. And I can really then start to forward plan what I want to ask or have some lines of thought in the back of my mind about what I want to ask. So it really starts the moment you dial that second 911 on your phone and you speak to our colleagues to get you the help that you need. So, what is an essential conversation, really? I pondered over this for quite a long time uh, when I was invited to join this community of practice over the past couple of months, and I've had these conversations with colleagues, friends, families, about what would you want to hear from me as a paramedic coming to your house? How would you define what an essential conversation really is? And when we reflect this in a palliative setting, we really want to understand that this conversation is aimed at understanding a patient's goals, their values, and preferences during a serious illness or end of life care. And we need to make this patient-centered. We don't want to have the conversation for my benefit. We want to have the conversation for the patient's benefit because they have called us for a specific reason. I need to really thoroughly understand what their values are, what their care preferences are, and sometimes what their end of life care preferences are. Because many, many years ago, we never wanted to have this conversation about serious illness or end of life care, but it's now very much a conversation we need to have every day. And for some colleagues at the very start of their career, it can be very difficult to have the conversation. It can be a very nervous and awkward conversation we have. I've come to learn that the more we have this conversation, your confidence grows and your voice will tremble at times when we have this with patients. But we need to have a bit of an analogy of slowing things down a little bit. We will often rush into a scenario where a patient is having an out of hospital cardiac arrest or a major trauma event or a heart attack, and we know exactly what to do, A, B, C, D, E, through a very set algorithm of what we need to do. However, during a serious illness or a palliative emergency, that's almost flipped on its head a little bit because we need to slow our processes down. Laura mentioned one of my hobbies outside is being out in nature, and part of that is being a photographer. And we have a bit of an analogy within the photography world called slow photography. And the less photos you take, the more you see of the world. And I can really relate that to paramedicine, that in the right scenario, the slower I am with my conversation and the slower I am with my care, the more I see about the patient. And I have a bigger lens and a bigger view of what's happening. And that really helps me focus my conversations of what I want to focus on with them. But from a paramedic's perspective, we really have three levels of emergency that we try and balance every day. We look at the acute emergency with your patients having a heart attack in the community as an example. We have a real specific practice guideline to follow those. We look at chronic emergencies where patients are often in chronic pain or there's chronic social conditions we need to be aware of and help fix. And then we have to look at the acute on chronic. What is happening at this point? And the acute on chronic is usually when we see a patient in a palliative emergency, and we can relate that to a breakthrough emergency. A patient has been managing their pain for such a long time. However, today something has really triggered a change in their care and their trajectory of care, and they've had to phone 911. So the essential conversations that we have are really critical discussions that we need to focus on understanding the patient's goals. And to provide a bit of context in that as well, in healthcare, these conversations are usually associated with palliative care teams and physicians. However, paramedics now in the community are very much part of that whole care team and that whole patient experience. As I mentioned earlier, we are often the first point of contact face to face with a person. And we can set the tone for future conversations and future care as well, whether that is a safe and appropriate non-conveyance or we are transporting and conveying a patient to the emergency department. My handover to an ongoing healthcare team is impacted by my initial conversation with patient, family, friends, and their loved ones to help guide their care with that as well, with the aim to really try and honor the patient autonomy and ensure that their care and our care really aligns with their wishes in an urgent situation. And we do need to be adaptable at times with that. As I mentioned, I'm really honored and proud to work in every community around BC, especially within our rural, remote, and Indigenous communities with the community paramedicine program. So having a wider understanding, how does my involvement and my conversation impact maybe some cultural thoughts and cultural conversations that family need to bring in as well. Can I be part of that? What do I need to learn? And how am I going to impact those? So these are all parts of the essential conversation. And then also explaining that both my tone and my choice of words can be really impactful. And then looking at the non-verbal communication aspect of this as well, my body language. How does my body language have to change when I'm meeting patients throughout the day, having these conversations at the worst time of their day when they need our support the most? So as I mentioned, we do encounter patients in their critical time. We interact them during the crucial times when the symptoms escalate and we need to manage that. Some of the opportunities to really align our communication style and our conversation style really come to play when we're responding to palliative emergencies or supporting patients requiring some hospice care. We have the opportunity here to really adapt our conversation style when we're managing transition between home and healthcare facilities, because we know that that is sometimes a very challenging, emotionally challenging environment for the patient, especially if we have to do supportive transfers from home to hospice. We still need to ensure that our conversation supports the family and the patient in their wishes. We're doing this comfortably, respectfully, and dignified with them, but also recognizing that this is a massive change in their lifestyle. And we can help support them as best as possible with that. And then navigating their goals of care throughout these acute situations. So being able to support families with what their priorities are. Often we think their priorities are getting care for their relatives, which is absolutely fine. But sometimes we need to also think about secondary priorities to them as well. Do they have their social needs sorted? Do we need to actually make a phone call to a neighbor on their behalf to help come and feed the dog or ensure the cats are still getting some food and water for the next couple of days because nobody's going to be at home? And then this all forms part of a whole patient experience and hopefully elevates their expectation and their satisfaction with us as paramedics throughout BC. When I first joined this profession 20 plus years ago, I was never exposed to goals of care. I was never exposed to advanced directives. It's been a very new process over the last 10 years, which has come into paramedicine, and they're very much established in secondary and tertiary healthcare. And we are seeing more and more in emergency and unscheduled care now. So, highlighting the importance of understanding what a specific goal of care is and what our ceiling of care is really important in the conversations as well. Explaining at times to patients that your goal of care may sometimes be above what we can provide, but then we need to think outside the box a little bit of how can we facilitate a process to get you that care and have a conversation about advanced directives as well. So some of our key goals when we're doing this is really emphasizing what we need to do for the day, looking and exploring the goals and values, slowing down our assessment process a little bit, understanding their fears and concerns. When I was back in the UK and working in a GP surgery, managing my own patient workload as GP, as with general practitioners as a paramedic, I would have 8 minutes to assess a patient. They would walk into my office and they would take a seat, and within that 8 minute time frame, I would have had to have a conversation, figure out what happened, come up with a care plan, whether that's either discharge from our services, refer into a specialty, or prescribing a plethora of medications to them based on a very short conversation with them. One of my first questions to them is, what is their fear? What is concerning you today? Or what do you think is happening today? Because if I can understand what's really brought them there, or what's really caused them to phone 911, or at the time 999 for me, and what their biggest fear is, I can work on a conversation plan in my mind to try and mitigate that and validate their concerns, but also work through some conversation pieces with them about how we can support their fears and support their concerns of what care they need in the future. So to do that, we really do need to emphasize some real active listening skills, listening with intent, listening with purpose. Are we actually hearing what the patient is saying to us, which is sometimes a very difficult conversation or very difficult process to go through. The patient may begin telling us their entire medical history, and we are so focused on one point, we often miss some real pertinent information leading up to what was maybe a diagnosis, then a reason for the call today. So active listening is a very key skill for us. And there's no real guidebook on that. I don't have a clinical practice guideline on active listening. I don't have a lesson plan on active listening when I'm teaching in schools. It's basically having the conversation with paramedics and student paramedics when I'm teaching to really focus on and be focused on what's happening at the time. Take out the conversation pieces that are coming to us, start to process and prioritize those, and then have an understanding about where they fit in the goals of care for the patient. So this is actually really important when we need to continue treating patients and talking to patients with a large degree of empathy and dignity, because recognizing that today that is their emergency and we need to meet it and manage it to their expectations, which is sometimes very challenging and difficult for us to do. There's three real points in this which I've kind of explained a little bit already, but we're going to explore the goals and values. Asking questions like, what is important to you today? What is your biggest worry today? And how can we help you feel more comfortable? Whether that's just patient positioning, explaining some medications that have been prescribed to them. That is a case that I've been involved in recently as a response paramedic. A patient was prescribed multiple new medications, and they just didn't understand the process of them. So having that conversation piece around them, it really alleviated their worries and stresses and taking time to go through that process with them. Then setting some, clarifying their preferences. So making sure that my care aligns with their wishes. And this relates back to exploring their goals and values. So, asking patients and families to really tell me what is important to their care today, and how can we meet that. But as I mentioned, this is really not a skill that is taught overnight. It takes a long, long time. Um, and we have so many new paramedics joining us in the community today that sometimes it takes a bit of time to go through this process. The way I learned is having the conversation. I have made some mistakes in conversation pieces in my career, and it's how we manage those mistakes and how we manage the conversations we have at the time. So, really speaking towards them, um, understanding what I've said. If I've said the wrong thing at the time, apologize immediately, recognize that um, maybe I'm still learning this process, and move on and get the support of the family, because I need to maintain the trust with the conversation pieces that I'm having. But building confidence as a paramedic can be really difficult. My biggest advice, and when I talk to patients and families, and students and even seasoned paramedics around this subject, is really review care plans. Take your time. We want to review the entire care plan. We may actually want to have the family to walk us through it, because that will give us the opportunity then to actually see, does the family fully understand what an advance directive is? Does the family fully understand what documentation we have here? And can we use this as a time there and then to do some public service education to them? Can we explain to them what a most form is? Can we explain to family and friends what an advance directive is and our roles within those? Using open-ended questions as much as possible. Instead of saying, "Do you want to go to hospital?" Um, we can maybe reframe that and say, "What do you feel is the best course of action for you today?" We know now that patients and families in the community, as I mentioned earlier, not everybody wants to go to the emergency department. They are very quickly learning how qualified and competent and experienced my paramedics around BC are, and we're fostering that knowledge to really empower people to have this conversation within their communities and within their patients. Again, adapting communication for cultural and situational context. I would have a totally different conversation with one of my colleagues from a clinical background than I will with a child or a 10-year-old. I may have a totally different conversation with a 10-year-old than I do an 18-year-old. And having the ability to really pivot my conversation pieces and alter my questioning around those, but still remaining on point with the narrative of what I want to get across and how I can support those. And then again, being able to provide emotional support for both patients and families and their relatives. This may just be simply signposting them to community services. This may simply be getting on Google or the search engines and finding out, is there a community center or a community group that they want to access into their region and get in touch with. Providing that support to them can be really powerful. We're not necessarily doing the onward referral, but we're also then empowering them and the relatives to take more control over their care as well. But we can signpost that and be a really important piece of the puzzle into their journey with us. We know this is a fast-paced world. Pre-hospital care is a very fast-paced world, so it takes a lot of time to build this conversation. And by no means am I expecting people over a 24-hour period or an hour lunch conversation to come away from this being competent and being fully confident in these conversations. But I encourage more and more listening as we move along with this. So, to give us a bit of an example about how this can work, I do want to share a story or a case from my career many years ago, and I've had to adapt it and loosely to protect this, and taken bits and pieces from different events to come up with a good case for us. But when we think about patients in the community, we really do need to understand what is happening at the time, and we need to balance it on their acuity. So many years ago, and as I mentioned, this is very much based on multiple cases in my 22-year career to kind of match what we're doing as an essential conversation. Um, I need to imagine that I was called to an elderly patient with advanced COPD, advanced respiratory distress. And the first thing she's saying to me is that I want to stay at home. I want to stay at home because we've gone through the process and they know what's going to happen when we go to the hospital. However, her family insists on transport to hospital. So my conversation piece in action here is really trying to figure out what is most important right now, recognizing that my patient has wished to stay at home, but I need to understand what the family's expectations are. I may potentially have multiple patients here that I have to have a conversation piece with. I know very clear in my clinical practice guidelines what I can do to support a patient with COPD who's in severe distress. I know what the hospital is going to do. And I also know what my scope of practice and my ceiling of care can do. But I need to understand I need to understand um, the wishes and the processes that the family are going through as well. Do I need to consider that the family may be experience some carer burnout? Are they exhausted? Is this patient actually relatively stable with her COPD, but the family are still working? They may have multiple jobs. They may not be able to get the care support that they need, and they just need some guidance and help, and they just really don't know what to do, which is often a very common case for us. So my conversation piece in these scenarios really was trying to figure out what's important to the patient, what's important to the family, recognizing that we have an express to stay at home, but also recognizing that we have an expression of family to go to the hospital. Then leveraging all of the tools that I had. I was very, very fortunate. Excuse me. I was very, very fortunate in my community where I worked. I had a fantastic relationship with the palliative nurse team and the palliative nurse specialists, where I could just simply pick up the phone to them and have a conversation. And by taking some time to listen in this scenario, engaging what is important to them, and it did turn out that the family was exhausted, I could get some care support in home. This patient was very comfortable to stay at home with some support and medications. We signposted the family to some support networks, but I also arranged for care support to come into the home overnight so the family could actually sleep and support and get some rest and recharge a little bit. For me, this then really meant that a patient who was experiencing a chronic disease and a chronic illness stayed home. She was comfortable in a home bed. She wasn't in a hospital trying to manage a chronic disease. This also meant that the family and their concerns were heard and validated. We recognized that they're exhausted. We had conversations about care planning and advanced care planning. And I also had conversations about patient deterioration with this as well. And what I actually experienced a couple of days later is a phone call from a crew, very early hours in the morning, directly to me, who had gone out to this patient again, who had a similar experience. A sudden deterioration. However, the family this time had, because we'd empowered them the first time, they'd made phone calls. They made phone calls to the nursing support team. They'd been able to contact out of hours care support, but they also contacted the emergency service as well for some immediate support. And we helped this patient stay at home again. We helped her stay comfortable at home. We recognized that there was multiple goals of care for her here. And through the conversation pieces that we had, we actually figured out a really good long-term plan for her. And she stayed at home comfortably and she passed away at home comfortably, surrounded by a family instead of in a hospital, which is probably when I very first started to come into a palliative education piece. This is one thing that really resonates with me about how our conversation is impactful with people. So, um, a bit of a call to action, really, to my paramedic colleagues and anybody who is here who is not in a paramedic environment, in a wider health care environment, whether that's a LPN, a support worker, a home care aide, a registered nurse, and nurse practitioner. The value that you bring to your patients is immeasurable. And the value that we bring to the wider healthcare communities as well is often inevitable for us. Okay. So my call to action to colleagues before I go to the next poll and open it up to questions is I really want us to think about the importance of paramedic involvement in our communication. How does our words matter? How impactful are they? What words are we going to choose? Have a bit of an understanding about the impact of these conversations. Um, Recognizing that we have options now to safely treat patients at home. We have the ability to support medication administration in the community. So we are not necessarily having to take patients to hospital for a pain crisis. We can support that through innovations and our palliative referral pathway, which links directly to every health authority within BC. Continue to learn, continue to understand what we do with our own professional development and future learning. Within the service, we have some very good, robust learning pathways. But I know that the BC Centre for Palliative Care, my colleagues at Pallium, have lots of publicly available education settings as well that we can use on the Learning Hub. Recognizing that our body language really matters, recognizing that our words really matter to the patient, the family, loved ones, and the wider community, and some of the questions that we are asking, and listening with intent, and then speaking with intent as well, and supporting families as best as we can. And then really to close off before I welcome it to any questions is just emphasize the profound impact that we can have during these moments. Our impact can be lasting and it can really change the trajectory of a patient's experience, both with us as a paramedic and then moving forward in the wider healthcare environment. Because if we have a good experience and a positive experience in one arena, we know that that stuff can be contagious and it can spread along everybody else. Recognizing that we are in a really busy environment. Initiating these essential conversations, having the confidence and the courage to ask these questions, we're going to help patients feel heard. We're going to help patients feel respected while supporting the families as well during a really stressful time. And then just to reiterate some of the main goals, understanding and exploring a patient's goal. What questions do we need to ask to do that? Using empathy. And open-ended questions to connect, recognizing that we need to respect the dignity of the patient and their wishes as well. And their autonomy is very powerful, and recognizing their autonomy. And then starting to integrate these conversations into our daily practice, which sometimes can be easier said than done, especially when we are extremely busy, and recognizing some of my operational colleagues, they are so busy, but trying to integrate this into everyday practice. And that's my challenge to people today. How can you integrate the principles of essential conversations into your practice? I do believe we have one final poll. As I mentioned earlier on, if the knowledge base is the same, that's absolutely fine, because that that gives me some really positive feedback to say, hey, I'm just not on point a little bit. If it's improved, absolutely fantastic. It still gives me some information to work on for the next time. So I'm not sure if Laura or one of the admins are starting that poll. If it's not, then we can. Oh, there we go.
It should be there, yeah.
Bit of a delay. So again, there's two questions. Has your knowledge level on today's topic increased because of the suggestion? If it hasn't, that's absolutely fantastic. I really don't mind that. If it's just a little bit, I'm taking that as a win as well. If it's a lot, then great. It all gives me something to work out. And then for the second question, we're looking at, to what extent does this echo session help you feel more connected to others interested in this topic? And I know that communities of practice are ongoing. The BCCPC do a lot on a regular basis, which we get a lot of support from, and a lot of network and sharing information with colleagues. So it's really interesting watching this and watching the results change as we go along. And I'm trying to figure out as they change what has made it change and what we can do to improve it next time. Okay. Wonderful. I think we've had a bit of a change, especially in the first question. We've seen a little bit of an increase, even if it's just a question in the back of your mind, that stimulates more questions and more conversations. I'm going to take that as a win, because you'll have that conversation in your offices over lunch. You'll have that conversation in crew rooms. You'll have it with some of my colleagues who you may meet in the community, and it can just generate conversation, and that can go wild, which is fantastic. Okay, thanks, Laura. I think happy to open this up to any questions or discussion pieces that want to come from this.
Yeah, thank you so much, Stuart. I think I have some comments in the chat there. So feel free to ask any questions in the chat, but we have Stuart with us for another 15 minutes. So we'd love it if you want to put your hands up and then go ahead and ask a question, or just go ahead and jump in. We can get a little bit of a discussion going with the time we have left.
Hi,
Okay.
Stu. Can you hear me okay?
Hi, Mayor. Yes, I can.
Yeah. Hi. Good presentation as always. My question is kind of the intent of the paramedic service, as there are nurses and other healthcare professionals that have a bit more of a specialty under their belt with palliative care and palliation. Is there an intent, as we see palliative care become increasingly popular in the home, is there an intent to have maybe our LRUs or some other units on the road that have a little bit more of that advanced training or some sort of certification that puts them above an entry level understanding of palliative care?
That's an amazing question. Yeah, I'd love to say absolutely yes, there is a plan to bring in palliative specialist paramedics. I know I'm doing a lot of work with our community paramedicine program at the moment and looking at urban and rural community paramedicine, who do a lot of work with community palliative teams and palliative patients out in the communities. So we are looking to investigate how we can expand their involvement throughout BC. At the moment, we are just in rural, remote, and indigenous communities, but we are looking at urban sites as well. Still really early days into that conversation piece and looking at how we need to balance it with scope, role, and referrals into those teams from 911 crews. Lots of things ongoing in the background. I'd love to share everything that's happening, but I just don't have the 5 weeks that I really need to tell you everything that we've done over the last year to do that. So short answer, yes, we're looking at expanding for you. Whether I just don't know how that looks immediately right now, but happy to kind of give you more information offline about that.
Great. Thank you. Yeah, that was a great question. Wanted to see if Omala still had a question to ask.
I do. Yeah. Thanks, Laura. This was a great presentation, Stuart. I loved every part of it. I think I work for a team where we really promote that goals of care conversations are a team sport. And I think that wherever a patient encounters someone in their care journey, we want all of those professionals to be part of that conversation. So I'm curious, how if a paramedic has a conversation like this with a patient, how do you communicate that to the next team that's going to support the person? Or, like if you help them to stay at home, how do you communicate that to the home health folks?
Yeah, absolutely. That's a really important question. And this was part of a palliative care project that we started probably 6 years ago before I joined BCEHS, looking at how we can support patients in a transition to transitioning their life in the community. We have a pathway called Assess, See, Treat, and Refer. So what we've actually set up is a process where a paramedic attends a patient in the community. Let's say, for the benefit of today, this is a palliative emergency, it's a breakthrough pain. We've had the conversation, we've documented the conversation in our documentation, our charting. Siren is the technology that we call. We've given some medications, done some supportive care. The patient has decided to stay home, and we support that decision. What we have the option to do is send electronically a copy of our patient report form directly to the health authority. And it's usually their community palliative team, either a central intake in some regions, and then that is shared to the community team that will visit the patient. And they'll actually have an exact copy of our patient report form so they can see exactly what we've done, our conversation. We also encourage a phone call. Simply pick up the phone to the care team from scene and have that conversation. Something which we never really thought we could do. We never thought we could just pick up the phone and speak to a community nurse specialist. But we're doing it and having that conversation now. So we have processes in place. It's 24 hours a day. From our side, recognizing that some of your teams are not 24 hours a day, but it will be picked up the next working day. And it's done live at bedside. So as soon as my crew hits the button in the computer, it automatically generates the form straight off to the healthcare team. So that helps the continuity of care there. We do have the odd occasion where some patients may not be attached to a physician, or maybe so early in their diagnosis that they're not attached to a palliative care team within the community. So what we also do in those cases, and these are very seldomly now, we will actually contact the patient again within the next 48 hours as a phone call, just as a bit of a checkup from my paramedic specialist in our dispatch center in Vancouver. Hey, we saw you a couple of days ago. I'm just seeing if there's been any change, any development. Do you need any more support from us? And hopefully in that time frame, the paramedics will have had the conversation about, we really need to contact your physician to get the ball rolling a little bit quicker. I hope that answers your question. I'm not sure if it does. If it doesn't, but I think that was it.
Yeah, no, it definitely does. It's helpful to know that you're able to at least share that with the folks that the patient is directly connected with. I'm also curious, and you may have said this in your presentation and I missed it, but is there specific education that BCEHS, like the paramedics, are able to access to build their skills for these conversations?
Absolutely, there is. Yes. So we have access to, over the past couple of years, we worked with Palliative National, and we have two LEAP courses, one aimed at emergency medical responders and primary care paramedics, which are our biggest teams of paramedics in BC. Then a second one for advanced care paramedics, which then talks about ongoing care and different medication processes. So they're available to all paramedics within BC that work for us to do that. And they're on the Learning Hub. And then we have communities of practices similar to this on a local and national level, where we can just share ideas and work with community teams as well.
I have lots more questions, but I think I'll let someone else.
That's okay. I'm more than happy if we want to chat offline. My details are there.
Yeah. Any other questions? I think I was also just curious if people can show hands or add in the chat if anyone's ever kind of been on the receiving end of one of these documented reports that Stuart mentions, if they've ever kind of read some of the conversations or read up on that documentation. Curious if anyone here has been on the receiving end of that or not. Doesn't look like it, but great that it's integrated and can be kind of uploaded automatically. I love that, Stuart.
Yep. No, it was a big development in our technology to be able to do that. And we have it's with every health authority throughout BC now that has access to that. And I'm getting daily requests as their team expands to come onto this, and then it's just developed, and it's a really cool experience. But recognizing that we only maybe see a palliative emergency patient probably once every couple of days in the community, and I think that that is probably a testament to some community teams, that they're treating their patients and they're seeing their patients so well. If we don't have to see you through a 911 event, I'm fine with that.
Yeah.
Stu, I got a question for you.
Hi.
Morning, afternoon. When it comes to the palliative patients in our care homes, we go to a lot of calls in care homes where they have their DNR advanced directive where it's comfort measures. But then the nurse assesses the patient, and it's 99% of the time it's mandatory by policy to go to a hospital where they can't treat on scene. And when we show up, whether it's just for nausea, they're just a little upset stomach, they can handle oral hydration, but they're just upset and they just need a little bit of gravel or like maybe some pain management that they can't provide. Um, the policy is to go to the hospital. We can't really develop a care plan to leave them at in their home where they're comfortable. We now have to remove them from their comfort. They're going to sit there for 10 plus hours in a hospital for something that we could have just done. But because the facility is adamant, it's our policy, we have to do this. And it kind of ignores the care plan that we could potentially develop. Is there any work that could potentially happen with the care homes that understands that, hey, like our paramedics can do assessments and then maybe we can like refer with the PS or something?
Yeah, I think what I'd really encourage is a bit of a change in the narrative with the conversation and say to our colleagues in the community now that, hey, I appreciate that this is maybe an institutional policy for yourself. However, we can support you in providing care for this patient. We can support you in making the referrals and the conversations happen in the community. And we can do that. Not necessarily meaning that we have to take patients to hospital, and it may be a difficult and conflicting conversation to have, but sometimes it may just be a really good point, a really good education piece to have at the time with the staff. I can treat this patient here for you. We
Mhm.
can do this. This
Yeah.
meets the goals of care. And I understand that you are concerned that we're not going to the hospital. But we can have processes in place to try and support the patient a little bit easier. However, there's always going to be that caveat that even if we have most forms, if the patient can't be treated in their long-term care center for whatever reason, um, then we may have to resort to an emergency department if they can't be made comfortable at home, if their pain is too extreme, or there's something going on that we just cannot manage there in a safe time. That's the only real caveat that we say, hey,
Right.
you know what? Absolutely, we've got to go to the emergency department to get you really comfortable, but then we'll work on getting you back home as soon as possible. It's having that conversation, as Tyne put in the chat, is paramedic advocacy. It is advocating for the patient, and she put it so well. How can we support health teams by also supporting the patient as well?
Okay. Thanks.
Yeah, that was a really great question, Armand, and I might reach out to you about that. Sounds like there could be some work in that area from my perspective. Great. Well, we are at 12:57, and I want to respect everyone being able to get back to their work at 1. So I think we'll close it out here. Just a reminder that the session has been recorded. We'll be kind of summarizing with some notes that we'll be sharing with everyone next week. And we'll also be sharing a link to this recording if you want to rewatch or share with others who might be interested as well, because I agree with Omel, and I found the information in Stuart's presentation really helpful, and really helpful to just understand the role of the paramedic as a nurse myself in these conversations, and how we all do the conversation as part of a team. So there will be a poll when you exit this session that we ask you to fill out, and this gives us really helpful feedback on how we design these sessions and future speakers and the cadence of the sessions altogether. And then, like I said, just look out for a summary with some notes about the session and then a link to the recording to share. And that will include contact information as well, if you have any kind of further questions or want to discuss more. Otherwise, thank you all so much for joining on your lunch break in this busy time of the year. And thank you, Stuart, for being here. And welcome to take off and get to your next part of the day. But thank you so much.
Thanks so much. Thanks, everybody.
Thank you.